The purpose of this presentation is to prepare you for your meeting with Pramila Jayapal. As you know, Pramila has stated on several occasions over the last 6 months that she wants to amend HR 676 before she reintroduces it in 2019. We have known very little about what her intentions were. On September 5, we got our first hint. On that date, I met with her briefly and her staff, and she told him she wants HR 676 to look more like S 1804, which is Bernie Sanders' bill. The one hint she gave him was that she thinks the prohibition on for-profit providers in HR 76 should be deleted. But other than that, we don't know anything more about her intentions. Our greatest fear is that she wants to import Section 611B in Bernie's bill into HR 676. You have 611B here in front of you. It's a single sentence. It essentially says that any quote-unquote payment reform activity that was authorized by the Affordable Care Act that applies to Medicare, or any reform activity authorized by MACRA, the dreadful 2015 law that succeeded the Sustainable Growth Rate formula, any payment reform activity authorized, currently authorized for Medicare by either of those laws will apply to the entire country, to the elderly and the non-elderly, on the day Bernie's bill takes effect. Now we've got to see if this can, here we go, good. This slide shows you some of the most frequently discussed so-called payment reform activities that would be applied to be not come up before it's enacted. And of these, probably the two worst are the Accountable Care Organization and what was at first called the Physician Value-Based Payment Modifier, authorized by the Affordable Care Act, that was then superseded by the Merit-Based Incentive Payment System program, MIPS. There are others here, but I won't take time to talk about them. Over the last 10 years, these cost containment schemes have come to be called value-based payment reform. And the grandiose assumption here is that they are improving not just cost and not just quality, but the two together. And those are value and cost and quality are both elements of value. I'm oversimplifying a little bit here because I haven't got a lot of time to describe all of this to you, but it's fair to say that value-based payment, these reforms you see here and others, have largely failed. They have not cut costs. It is conceivable that bundled payments for joint replacement may be the exception to that rule. By and large, these so-called reforms are not cutting costs, in part because the administrative costs of running these schemes is fairly high. And this is even less well known. These nostrums are worsening health disparities, racial and income disparities. And if I could wave a wand and and make one thing happen after your meeting with Pramila is over, I'd like to see her saying, yes, I understand that value-based payment is not what it's cracked up to be, that it doesn't cut costs, possibly in some cases it increases costs, and it worsens disparities. That would be the ideal. There are, of course, other issues that need to be discussed with her as she goes about amending HR 676, but this one, in my view, is number one. If 611B is not deleted from Bernie's bill, and if, God forbid, it's imported into HR 676, we have an enormous problem on our hands. The cost-cutting ability of these bills will essentially be sabotaged. The other major defect in Bernie's bill is that it doesn't contain any hospital budgets. As you know, HR 676 currently does have budgets for quote-unquote institutional providers. And that combination of 611B and no budgets for hospitals in Bernie's bill is lethal. It means there's going to be very little cost containment on top of a worsening of disparities. I would like to take just a little time to offer you a historical context here to give you my view of the high stakes here of your meeting with Pramila, and presumably with some other PNHP meetings with Pramila that will follow. I think you've all heard the name Ted Marmer. He teaches health policy at Yale. He's the nation's preeminent expert, Medicare historian. He and I crossed paths in the 1990s, wrote a couple of papers together. In 2014, Yale Law School decided they wanted to do a conference celebrating the 50th anniversary of Medicare. And Ted being on the faculty on the Yale faculty, they approached him about writing a paper, and he said yes, and he approached me about being a co-author. The topic he wanted to discuss was why in the 50 years that Medicare has been around, has Congress never seriously considered expanding Medicare to everybody? And we worked on this paper through much of 2014, and to make a long story short, this is a paper, if you Google my name and Ted Marmer at Yale, you'll find a digital copy. It's pretty long. But we talked about the obvious reasons. Money played a role. But an important role that we thought doesn't get a lot of attention was that managed care, which is the term developed in the 1980s to describe tools pioneered by HMOs, that the managed care movement essentially robbed the single-payer movement of Democrats who were passionate about universal coverage, who should have led the fight for single-payer, but didn't. The earliest example was Ted Kennedy. He introduced a bill along with Representative Martha Griffiths of Michigan in January 1970 that today we'd call a single-payer bill. But within a few months, he had been seduced by this newfangled form of insurance called the Health Maintenance Organization. And he was a managed care advocate from then until his death. He was never again a single-payer advocate. Fast forward to the 90s, Bill and Hillary Clinton. They were never single-payer supporters. They were totally taken by managed care theology, and to this day, to my knowledge, they still oppose single-payer. Fast forward to 2009, President Obama is now in a powerful position to influence the debate about universal coverage. He campaigned in the Senate as a single-payer advocate, but by 2009, he was clearly not a single-payer advocate, promoted what is essentially now being called value-based payment reform as his method of cost containment. And I fear greatly that Bernie Sanders now will join this illustrious list of prominent Democrats who had an enormous amount of clout, were in a position to promote a debate in Congress about extending Medicare to everybody. And he's not going to do that because he has been seduced by managed care. I'm fairly confident that that's the case, and we can get into a discussion about attempts that we and others have made to get Bernie to talk about 611B. They're not going to do it, according to the latest information we have. And my great worry is that Pramila will join that list, and I'm quite confident she's been influenced by managed care thinking, value-based payment hype. And I'm only hoping that she's still new to this debate. She's a new member of Congress. She really is going to be open to what we in PNHP have to say. But I see your meeting as a very important first step in making sure she doesn't join Ted Kennedy, Clinton, Obama, and Bernie in walking away from single payer and endorsing managed care. If I think about what I would like to do, if it was just me sitting down with Pramila, of course, nobody wants to lecture. We want to find out what she's thinking. And we'll get in a minute to the agenda that David sent me that I think, David, you and Matt Petty, PNHP's director, put together. But my goal would be to develop a collegial conversation with her that essentially helps me figure out answers to several questions. Number one, does she grasp how powerful single-payer systems are at cutting costs? Or does she doubt it? And if she doubts it, is that why she might be interested in value-based payment nostrums? Second, does she have an accurate diagnosis of why American healthcare costs are double those of the rest of the world? Our costs, contrary to establishment mythology, are not double those of the rest of the industrialized world because Americans overuse healthcare. Yes, there's some overuse, but the primary reason we are such an outlier is that our prices are sky high, and they're partly because there's no competition, no regulation, and partly because we generate enormous administrative costs in running our complex system. Third, I'd want to know what she knows about value-based payment reforms. Does she understand they don't cut costs, and does she understand that they worsen income and racial disparities? Just to recap what I've just said to you, you see the fundamental equation you've known since you were 6 years old here at the top of this slide. If you want to know total spending about anything, be it bananas or healthcare, you've got to know two numbers. You've got to know the price of bananas and the quantity of bananas sold in, say, 2017. You take price times quantity of bananas in 2017 and divide by 330 million Americans, and you have per capita spending on bananas. Now, in the infinite wisdom of the managed care Illuminati, who have dominated the debate about healthcare reform in this country now for half a century, quantity is the problem. And you rarely hear anybody say anything about price. Starting with Paul Elwood's paper to Nixon, there was nothing about price. It was all about how the fee-for-service system induces greedy doctors to order services patients don't need, and that's why American is suffering from high healthcare costs. You see here a quote from the Wall Street Journal, an op-ed by Drew Altman, the CEO of the Kaiser Family Foundation, basically saying what I've just told you, I've just said to you. America has obsessed about volume. We've done almost nothing about price. Here, to be more specific, is the theology that I fear Bernie has succumbed to, and Pramila has succumbed to, or has been influenced by. There's a false or inaccurate diagnosis, and there's a false or inaccurate solution. Diagnosis is that quantity is the number we need to obsess about, and ultimately we can blame fee-for-service for that. And if you buy that diagnosis, then your brain is inclined to say, well, shoot, the solution has to be to turn the fee-for-service incentive upside down. We do that by exposing doctors and hospitals to the equivalent of insurance risk or partial risk. And in the event that, and just in case that doesn't work, we will micromanage them with utilization review and click for pay and other schemes. That's essentially, and I'd like to know to what extent Pramila accepts this. Here's an example of the doctors are to blame for overuse diagnosis. It's taken from an op-ed in my hometown, Minneapolis Star-Tribune, by CEO of Blue Cross Blue Shield Minnesota, basically saying managed care has saved money. It hasn't, and it did so by turning the fee-for-service incentive upside down. Here's Roger Feldman, a name you may recognize as well, a conservative health policy economist, observing with some astonishment in 2015 that we have a remarkable consensus that fee-for-service has to be destroyed. Why? Because it increases volume. I agree with him. It's remarkable that this consensus exists because it's never been demonstrated, and yet it has formed the basis for American health policy for half a century. Conservatives have contributed to this by also yammering on about overuse, but in their case, they blame patients, not doctors. They say we're overinsured. We only pay 10% for our colonoscopies, so we get 2 a week because we just can't get enough of them because they cost so much less than full price. And here's one last piece of evidence about how the establishment obsesses about volume and why I'm fairly sure Pramila has heard this and has been influenced by it. This is from the Medicare Payment Advisory Commission's report to Congress in June 2009. They had just, in the last year, begun to endorse accountable care organizations. And here you see the mantra. We need ACOs to overcome the incentives in the fee-for-service system that drive up volume. Volume. Nothing at all about whether ACOs will drive up administrative costs or encourage consolidation, both of which drive up price. This is the agenda with one minor change that David sent to me that I gather, David, you've had some conversations with Matt about. It's an excellent agenda. And you see that the first 2 bullet items are process items, and the next 2 are substance questions. The first one asks about Pramila's timeline. When does she want to make these revisions? The second one asks her, who are you talking to? The third one asks what provisions in S18 and 1804 is she most interested in importing into 676. Fourth one asks, and what is there something in 1804 you wouldn't want to put in HR 676? And then you see in red my addition, David. I pulled that up from the bottom because I just think this is if you have half an hour with her or 1 hour, this is the topic you have to discuss with her. I realize there are other issues that people have with Bernie's bill or that she may have with HR 676. But if she does not understand what's wrong with 611B and proceeds to put it into 676, you're in real trouble. And a lot of the other coverage issues, weak long-term care, deductibles for drugs, we're going to lose on if we can kiss those issues goodbye if we can't solve this, if we lose the ability of single-payer legislation to cut costs. Now I'm going to rush through several types of evidence on this question of what is the proper diagnosis? Is overuse really the correct diagnosis? That I would like to ask Pramila that. Pramila, when you think about why America has costs double those of the rest of the industrialized world, and you know that price times quantity gives you total spending, where do you come out on that? Do you agree with the establishment that quantity is the problem? There are four types of evidence that overuse, that volume, is not the major issue. First of all, research shows that overuse, research actually demonstrating overuse is limited to a tiny handful of medical services. Two, there's no evidence linking fee-for-service or overinsurance for that matter with overuse. Believe it or not, that's true. The third type of evidence is that research shows underuse is far worse than overuse. I almost never hear value-based payment advocates, managed care, acknowledging that. And so if you don't acknowledge that underuse is rampant, far worse than overuse, you are more likely to feel free to get out your chainsaw and go after overuse and not worry about aggravating underuse. The last category of evidence is the most convincing in my mind. Americans use fewer medical services than residents of other countries. Those other countries have lower costs. Ergo, price can be the only reason why U.S. costs are so high. I'll give you just brief examples of each type of evidence, each category of evidence. This is from a study done, published in the Archives of Internal Medicine in 2012 by Korenstein and al. They looked at 20 years of research looking for evidence establishing overuse, and they found very few studies. You can see that they found that the studies were mostly limited to antibiotics and 3 cardiovascular procedures. Now the next slide is really, it's almost funny. It's a comment by the editor of the Archives of Internal Medicine about this paper. Here's what he said. What is most striking about this report is how hard the authors searched for data on overuse. They viewed 21 years of medical literature and evaluated 115,000 publications, yet found only 172 articles that addressed overuse of healthcare. Here's a statement by Mark Chassett, a well-known health policy expert. He says there's never been a direct association with a fee-for-service payment overuse has never been established. Said that in Health Affairs. Now we go to the underuse issue. I'll show you 2 studies. This was a rather well-known paper done by Elizabeth McGlynn and colleagues at RAND, published in the New England Journal of Medicine in 2003. They found it excellent. Must have been a very expensive study. Found that underuse occurred 4 times as often as overuse. Here's a paper by people at the VA. Found underuse was 22 times worse than overuse, and I kept the source in big fonts here because I like the title. Sins of omission, getting too little medical care may be the greatest threat to patient safety. Now, how iconoclastic is that? All we hear the Illuminati talk about is overuse. We've got an article here suggesting that maybe underuse is a bigger problem. And then the fourth category of evidence is that the U.S. Americans get as much or less health care as people in countries with much lower spending. We see our doctors less often. We are in the hospital less often. We skip care more often. Why is underuse so common? It's obvious why. Money. People can't afford it. People fear doctors. Doctors don't have enough time to deal with every issue patients can come into the clinic with. Here are two, I'll give you now 2 slides documenting that price is the issue. You may have heard of this study run by Gerard Anderson at Johns Hopkins, Yuval Reinhardt when he was alive at Princeton, and a couple of others in Health Affairs. They examined use rates and prices and concluded it's higher prices that explain why U.S. costs are so high. And here's a more recent paper in The Lancet making the same conclusion. It's prices rather than volumes that explain why the U.S. costs are so high. And you've all seen this kind of data in the PNHP slides. Drug prices are higher. Our hospital costs are higher. Our procedures are higher. Costs are higher. So just to stop and review what I've just said to you, I would like to hear Pramila. I'd like to, you can't be there obviously, have a conversation with her that elicits from her whether she thinks that this 50-year pursuit of the fee-for-service method of paying doctors in order to stop overuse is really what we should have been doing for the last 50 years, or whether we shouldn't have been paying more attention to price and the administrative waste that drives prices up. And you all know that that's what HR 676 and any true single payer does. It focuses on price. It reduces price 2 ways. By going from a multiple payer system to one payer, you reduce the insurance overhead, reduce the overhead in the insurance sector by large amounts, and you reduce overhead amongst providers as well. And by reducing the overhead costs in both the insurer and provider sectors, you greatly reduce administrative costs, possibly to the tune of 15% of the $3+ trillion America spends on healthcare now. The other way single payer systems, true single payers reduce cost, is to set limits on what doctors, hospitals, drug companies, and equipment manufacturers can set their prices at. Currently, anything goes. Competition doesn't work, and we have no regulation. So those are the 2 methods by which single payer gets at price. There are some ways a single payer can get at quantity, for example, adjusting the price of C-sections downward if we think they're being used inappropriately. But by and large, it's accurate to say single payer is focused on price, which is where the focus should be. Now I want to take the last 5 or 10 minutes here to document just 2 claims that value-based payment, aka managed care, it's the current iteration of managed care, doesn't cut costs, but it does worsen disparities. It harms the sickest and the poorest. And I'll just use ACOs as an example. I've got a lot of slides in this set. I won't inflict them upon you tonight. The reason why any value-based payment nostrum worsens disparities is that all of them shift risk from insurers to doctors and hospitals. That's what you get if your diagnosis is that fee-for-service causes overuse. If that's your diagnosis, your solution then is to turn the fee-for-service incentive upside down, and you do that by shifting either all risk to doctors and hospitals with the form of capitation, or partial risk, which is what you do when you do shared savings nostrums like ACOs. Under a shared savings program, Medicare, for example, will assign Medicare beneficiaries to an ACO, Montefiore in New York, Partners Healthcare in Massachusetts, Banner in Arizona, Alina here in Minnesota, and they'll say, okay, by our method, we're going to assign these patients to you. We can talk to you more about that if you want to know how that's done. And these are the patients you will be responsible for in 2019. Let's say this is being done in 2018. And if you keep your per capita spending below a certain amount, we will split the savings. If you go over the per capita amount, we will split the losses. That's how shared savings risk shifting works. But whether it's full risk shifting or partial risk shifting, the need for predicting what that pool of patients should cost stares you in the face. With a fee-for-service payment method, you don't have to predict anything. As the patient comes in, doctor orders the service and submits the bill. But with managed care and value-based payment schemes, you have to predict in advance what a particular pool of humanity is going to cost. That has never been done accurately and never will be done accurately. And because it's done inaccurately, it punishes the providers who treat the sickest and the poorest. And I'm going to show you in a minute a table that demonstrates that. The table shows you how inaccurate the CMS's, Medicare's risk adjuster is. That's the phrase we use to describe adjusting these per capita payments to hospitals and doctors to reflect factors that are outside of provider control. The big one, of course, is the health, the status of the patient's health, but others matter too. Income, the neighborhood you live in. CMS, Centers for Medicare and Medicaid Services, was pushed by Congress in the late 90s to start developing a more sophisticated risk adjustment method than they'd been using ever since 1972 when HMOs were first allowed into Medicare. Up until the late 90s, all CMS used was gender, age, and Medicaid status and institutional status. Were you in a nursing home? And those factors together explained about 2% of the variation between Medicare beneficiaries in terms of cost. After 15 years of working on it, CMS now has something called the Hierarchical Condition Categories Risk Adjuster, the HCC Risk Adjuster, and now it explains a whopping 12% of the variation in expenditures on Medicare beneficiaries. Now, how bad is 12%? Well, this next chart shows you. This is from MedPAC's report to Congress, June 2014, page 30. You can look it up. You might want to read that entire chapter yourself. I think it's chapter 2. It's a very accessible discussion of how difficult accurate risk adjustment is. Now, what CMS did, just to test the accuracy of its latest version of the HCC risk adjuster, was to divide, pull a sample of 12 million Medicare beneficiaries and apply this risk adjustment algorithm to them, and they broke their sample of 12 million into quintiles. And look what happened. This risk adjustment method, which is probably the most accurate on the planet, over-predicts the cost of the healthiest 20% by 62%. So if you're a Medicare Advantage, and this is, by the way, they developed it primarily for the Medicare Advantage program, but now they're applying it to ACOs and some of the value-based payment programs. So if you're an ACO and you know that you're going to be overpaid if you can get the healthiest 20%, you have an immense incentive to attract those people and avoid people at the other end of the spectrum. You see on this table that the sickest 1% are underpaid by 29%. And that's, as somebody put it, that's the reverse Robin Hood effect. You're taking from the providers who are treating the sickest and the poorest, and this means probably the blackest and the brownest, and you're giving money to the providers who are seeing a whiter, healthier, and wealthier population. And you can imagine what that's going to do to disparities. We can talk more about the mechanisms by which that happens later. Now, if I can find it quickly, I want to just show you a chart that shows you how totally inept Medicare's ACO program has been. There was, Congress actually saw fit to run a demonstration of the ACO program between 2005 and 2010. It was called the Physician Group Practice Demonstration. You see here at the top, PGP demonstration. It selected the creme de la creme of the American managed care groups. 7 of them had experience with HMOs. And you see the net result. They saved Medicare a grand total of 0.3% over the 5-year period. And that's not counting the overhead costs that the ACOs incurred attempting to save money for Medicare. The Pioneer program and the Medicare Shared Savings Program, that's what MSSP refers to. You see here Pioneer and MSSP results. They were both started in 2012 under a mandate from the Affordable Care Act. And you see the results by year for the 32 ACOs that started out in the Pioneer program. By year 5, they were down to 8. So if you used an intention to treat analysis, this would be a miserable performance. But you can see that, again, highly vetted 32 organizations that CMS selected to be in the program could barely save a few tenths of a percent, just like the PGB demo. And again, if you count the cost that the ACOs incurred to run their interventions, total cost went up. And you see the Medicare Shared Savings Program did even worse. They lost a tenth of a percent or so every year. The last item you see here is the Next Generation. It's the successor to the Pioneer program. The Pioneer program ended in 2016. Next Generation is, you can see, doing an equally impressive job, saving a magnificent total of 0.2% in 2016. So I'm going to stop there and just summarize again what my fantasy vision is when you guys get up from your meeting with Pramila. Pramila's going to say, boy, I get it. I understand the single payer is a powerful solution to America's high costs, and we really don't need to improve it with anything else. Maybe we need to improve some aspects of the coverage in HR 676, but we don't need to tinker with the basic cost containment mechanisms. Secondly, I'd like to hear her say, you know, I've heard that Americans' healthcare costs are double those of the rest of the world because these greedy doctors succumb to the fee-for-service method and they order far more services than patients need. This doesn't happen anywhere else on the planet. We really do need to, I want to hear her say, I understand that's bunk, vastly exaggerated, and that price is the problem. And I understand that single payer really focuses on price. Thirdly, I understand now that value-based payment reform has a miserable track record. It's not cutting costs, with possibly one exception, hip joint replacements. And probably most disturbing, what I learned from you wonderful people at Washington PNHP is that value-based payment reform worsens disparities. You've convinced me. I'm not going to import any of that nasty stuff from Bernie's bill into HR 676. Thank you so much for inviting me to talk to you. Thank you, thank you.
What's your second one, Marty?
No idea.
Well, I just wonder about the what's going on behind the scenes between Bernie Sanders and Pramila Jayapal, because I wonder about the influence of, I come from Vermont, and I know that the one business that has any power in Vermont is insurance. So I'm really wondering about what's going on with, you know, the whole campaign financing and the insurance companies and these two particular really important people in our, in the process, because I think it's good to have some idea of what may have come up between the last time we were, you know, they seem to be moving in a better direction, and now I guess is one thing I'm wondering, and if you have any insights in that.
That was my question, exactly.
If I had to guess what's going on, money is not the issue with Bernie. It may be with some of his colleagues. I'm sure it is an issue for some of his colleagues, many of his colleagues in the Senate. I think the power of this managed care diagnosis and solution is the main enemy here. And let me just give you, report to you what happened with Keith Ellison. Keith is my representative. He and I go way back. He was a single payer advocate when he ran for Congress. And as soon as he became the chief author of HR 676, my organization, Healthcare for All Minnesota, and the Minnesota chapter of PNHP, asked him for a meeting. This was in March, and we attempted to open a conversation about Section 611B. And Keith shut us down with a rather snarky remark. He said, people need shoes, and you guys want to talk about shoe color. Now, I'll bet you a lot of money, nobody paid Keith to say that. I think he doesn't understand the problem. He thinks we're being holier than thou. We don't want our precious HR 676 messed with. And Keith has now refused 4 or 5 other attempts, a personal email from me and several letters from Minnesota PNHP and HCAM, the group I work with here in Minnesota. I just offered that as one illustration. I'm fairly confident Keith Ellison can't be moved on this issue by money, and no one paid him to make that slightly disrespectful remark. I think what's going on is that there is some group or coalition of people, and I really hope Pramila can shed some light on this, who have been lobbying Democrats since approximately this time a year ago, including Bernie and Keith and Conyers and now Pramila, to inject value-based payment nonsense into the Senate bill and into HR 676. We know that Dan Riffle, who used to be on Conyers' staff, made a comment last fall to a magazine called Rewire, saying we have to update HR 676. We have to move away from fee-for-service toward outcome-based programs. That's another word for value-based payment. They had gotten to Conyers' staff by about this time last year. Someone's clearly gotten to Bernie, but I, for the life of me, I can't find out who's doing this. We do need to find out. And here's another way to put the question. Why did all of those people, Bernie, Keith, and I would argue Pramila, fail to reach out to PNHP first? Why are we pulling teeth to get meetings with them?
I've had this experience just recently with how deeply penetrated into like the Washington State Medical Association, this idea of managed care and value-based payments, because I'm a member of Washington State Medical Association. I get their literature and stuff like that. And I've been inquiring with them about certain continuing medical education courses that they have because I need some CME for my license. And a lot of what they have in their literature, they'll have whole booklets on how doctors need to adjust to this new regimen of value-based payments. And this is just the way it's going to be, and this is how you adjust to it. And they talk about, maybe you need to see a psychologist to work out your feelings about this and all kinds of stuff. But it's like, it's so permeated in like the hierarchy of the state medical society, and they have continuing education courses, that teach you how to adjust to this. I just found it was like very interesting, in my pursuing continuing education, how much is about that.
Yes, and if you ask me why this managed care theology has had such a long run, you'd have to point in part to the abdication of any responsibility to debunk it by the AMA and the state chapters. They should have been out front doing this research that you heard me present and that PNHP has presented in the past. They aren't. And if I had to pick one of the specialties, I'd pick the American College of Physicians. They've got somebody blogging regularly about macro. What a useful, what a wonderful law that was.
In addition to the request for slides, I think it'd be valuable. You may already have such a document that succinctly summarizes all your arguments, but with a list of references so that people can get into something in depth for the original data supporting your conclusions. And that's something that will be valuable to have in a discussion with Pramila, I think, and others. Do you have such a document already?
I wrote a 2-page version and an 8 or 9-page version. The 8 or 9-pager is the better of the two.
Does it have references?
No, that's a good point. I was essentially trying to put together something people could read quickly at the single payer conference here in Minneapolis late in June. There are links, but it's by no means as well documented as it could be.
That's helpful. You know, there's another question that I constantly ask. Why is it for all those many years, HR 676 was waiting for somebody in the Senate to introduce a companion bill? Why didn't Bernie do it? And why didn't anyone else do it? And that might be very informative to understand who got to them, what was the pressures that prevented that obvious next step. They had lots of time to do it. So do you have any insight to that?
As you know, Senator Paul Wellstone was the first to introduce a single-payer bill in the Senate in 1992, but when he died, nobody picked up the baton. And then Bernie introduced a bill that has problems like his current bill in 2013, but he either didn't try to get co-sponsors or he couldn't. So you're absolutely right. There's something going on in the Senate. We've had much more success in the House ever since Representative Marty Russo from Chicago introduced the first single-payer bill, modern single-payer bill in Congress in 1991. You know, it might be the fear of money. You know, advertising pays off at the statewide level in a way it doesn't pay off for the smaller congressional districts. That's where money that may be the major factor.
In the best of all possible worlds, to address the issue of price, were decent legislation to go through, how do you see physicians being paid? As simply as a negotiated fee schedule like they used to do with the auto workers every 3 years, and like they do in other countries, or some other way that's more simple and more efficient than calculating all this RBS nonsense and value-based payment, just a negotiated fee schedule? Is that something that is in the works or in people's thoughts? How do you pay physicians and set their prices?
The standard process in countries that have both multiple payer and single payer systems is a regular negotiation. So like in Germany, which is not a single payer system, the government gets the sickness funds and the doctors together. I don't know if it's every 2 years or annually or every 3 or 4 years. And they just negotiate. Whether they use the RBS system or something like it, I don't know. I think the important thing is you've got now government using its power as a buyer, what economists call its monopsony power, to either directly negotiate or supervise the negotiations with doctors. Is that the answer to your question? Would negotiations be involved? That's presumably what would happen, but I don't think either Bernie's bill or 676 specifies negotiations. I think California's bill does. I think Minnesota's single-payer bill does.
No, that's the answer. I studied the British National Health Service, and that's what they did every couple of years. Doctors would get annoyed, they'd appoint a royal commission, they'd negotiate it, and they'd go home for a couple of years. And just on and on like this. So that's how they did it.
And are you satisfied with that? Is that a reasonable process?
It worked for them.
Yeah.
Just a brief comment. I come from Norway. It's been quite a while since I've been working there as a physical therapist. But I know back then, when I worked there as a physical therapist, the association negotiated, with the health authority of Norway, about the rates and so forth. And the doctors did the same. So, and to me, it was simple and very easy, and much preferred rather than the value-based system that they're trying to, do right now.
And can I add that the value of having the government either negotiate directly with doctors or supervise negotiations, as is the case in multiple payer systems, value is you couple that with hospital budgets and you've taken away the incentive for our healthcare system to consolidate. We have been hurtling toward a highly consolidated system really since the early 90s, and the Affordable Care Act set off another mad rush to merge. And of course, the people that are merging, the CEOs in charge of the mergers, always explain this is for the benefit of society. We're doing God's work here. We all know the reality of it. They're doing it to a mass market power because they understand they're in an arms race, and you dare not be the last person to join a giant fiefdom here, or you lose out. The minute you remove from the big hospital clinic chains the benefit of merging with yet another hospital, you take away from them that we will then slow down and ideally reverse the consolidation that's threatening both cost and democracy in this country. I want to just tell you about a provision that we have here in our Minnesota single payer bill. Our single payer bill, like virtually every single payer bill I've seen in this country, specifies budgets for hospitals. As we watch the rush to gigantism occur in this state and across the country, it occurred to Minnesota PNHP about 4 years ago. We need to refine that provision. Now what the provision says is the Minnesota single payer will establish a budget for each of Minnesota's 134 hospitals, and the single payer board is prohibited from negotiating a budget with any entity that owns more than one hospital. That way we penetrate the corporate cover, and we don't reward the 800-pound gorillas for being 800-pound gorillas. Moreover, this isn't in the bill, but maybe it needs to be, we expect that the single payer board won't pad the budgets of hospitals that are in these big chains to pay off their administrators. And eventually, in my fantasy, the chains just wither because they're not being paid to do anything. The state has taken over the function of the cartel management, and they're not being paid, and they disappear.
You're fired.
Yeah. Or the CEO of the cartel can be in the hearing room while the single payer board sets the budget for each of its 14 hospitals, but they're just a spectator.
A couple of things. One, do you have hard evidence where Pramila said she was looking into value-based payments? Because there was a comment there, was a truth dig or something a few days ago, with her making a statement that she didn't want the Medicare extra type plans coming into the new health Medicare for All caucus. The other thing is there a congressperson out there that you think is really trustworthy as far as single payer and improved Medicare for all? Who's your top political person in Congress?
To answer your second question, no, I would have thought Keith would have been that person. When he first ran, I was convinced he could never be pushed off single payer. Now I'm not so sure. And when I read the comment by John Conyers' former health policy guy, Dan Riffle, this time a year ago, we have to move away from fee-for-service to value-based payment, I about fell out of my chair. It means that the experts have already been influenced. So the answer is no. At this point, I don't know anyone that knows this stuff well enough that they can be trusted to be, we can treat them as immunized against value-based payment hype. On your first question, I hope that nowhere in my presentation did I say we know Pramila has already endorsed value-based payment. We don't know that. I suspect, and I believe for the reasons I've laid out, that she's been lobbied to endorse it, and she's either already endorsed it, I suspect she's already accepted it, or she's been influenced by it. That's all I want to say. And I like the agenda that David and Matt Petty developed, because you're going to find out pretty soon when you ask her, what is it about SA 204 you like? She says 611B, boom, we're going to have our answer. I do think it's extremely important not to confuse value-based payment reform with any version of the public option. I know that Pramila has rejected the Medicare extra, the Medicare buy-in proposal that was put out there recently by I forget who, precisely to kind of drag Democrats back from the single payer proposal. But that's totally different from the value from Section 611B. It's got its own problems. It won't work. I'm glad she's not enamored of it, but it's a separate issue. Just because she's opposed to the Medicare extra doesn't tell us anything about what she thinks about 611B.
Okay, Kip, thank you for joining late at night. We appreciate you coming and speaking with us. One question I had was, it seems like a lot of the work that PNHP and past single-payer advocates have done is, very complex, almost backdoor political maneuvering of, finding data, finding papers, and presenting those to key congresspeople. And I'm wondering if you could, I wanted to get your opinion on what balance you think there should be between this sort of political maneuvering that we're doing even at this meeting now versus, taking the time to actually build a social movement towards single-payer and universal health care. I feel like, as we've seen in the past, there's just been a lack of political will by both congresspeople and senators, and I believe that that's because of the lack of sheer number of people. Just last week I was conversing with a nurse who had no idea what single-payer healthcare was. Yeah. And so what balance do you think that we should concentrate our efforts towards this maneuvering versus actually building a social movement towards single-payer healthcare?
Well, I see a good bill that moves in Congress and base building as mutually reinforcing. I don't see them as antagonistic. In fact, I see a good bill on the flagpole that gets some attention as really helping base building, grassroots base building. We're talking about that here in Minnesota as well, both Healthcare for All Minnesota, the citizen group, and Minnesota PNHP. It's the perpetual question: how can a raggedy-ass little citizen group without a lot of money compete with the insurance companies? And what I think we have to do is think just a little smarter about how to give people who are not on the boards of our organizations regular activities to engage in, preferably in their community, so they don't have to truck into St. Paul or Seattle to be part of a rally or something, that is coordinated by the state board. Because nobody wants to door knock or hold a coffee party for 5 people all by their lonesome. They're motivated to do that kind of grassroots base building when they can see they're part of something bigger. And that's the piece we have to start figuring out. But as long as we have small budgets, we have to figure out how to do it without burning out the board. The board serves a very useful function. What you're doing tonight is extremely useful. But we need to do it in a fashion that doesn't burn people out. I think it's entirely possible. It just has to be thought through. The board has to say, for example, we're going to develop a campaign to create little groups of maybe no more than 6 people in each house, state house and Senate district in our state. And we're going to start finding them now. We're going to put little red dots on a map, and we're going to kind of treat it like a thermometer in a fundraising campaign. We're going to get people excited about placing knowledgeable people throughout the state. Their job is to visit with and develop relationships with their legislators, develop relationships with local media, and to do other base building activities that we often talk about. Book meetings, training sessions, whatever. So that's a short answer to a complex question. I see base building and a good bill and moving the bill as essential. It's harder to develop an army of activists when there's nothing happening in your state capital and nothing happening in Congress. It's gotten easier to organize single payer when at least it's getting a lot of attention in the media. So having a bill on the flagpole, getting it moving is useful, but and it's a virtuous cycle. It helps build the base if you got a good bill. God help us if we have a bad bill.
So, just really quickly, your June 2018 critique is focused on 611B, but a lot of us are really worried about Bernie's bill, the aspect of it that's maybe some people think is like a poison pill. That is the gradual introduction of it year by year. And so the opposition may jump on it after the first year. You see, we're not saving any money. It's nonsense. That worries a lot of us. Are you concerned with that as well?
I share that concern, but let's keep in mind that something this complicated will require, I think at minimum, a 2-year phase-in. And is my memory correct? Bernie has a 4-year phase-in? My major objection to the 4-year phase-in is that it just gives these value-based payment nostrums a lot longer to dig in and make trouble. And that, I think, is the real issue here. As those value-based payment nostrums continue to fail to cut costs and worsen disparities and irritate doctors, we give opponents of single payer even more ammunition to shut it down and stop the phase-in entirely. So my preference is HR 676. I can't remember now if HR 6, what is the phase-in time for 676? Is it 2 years? I'm not sure what it is. What is it?
1 year.
1 year. So it'd be a short phase-in and no monkeying around with programs like ACOs and MIPS to give. We need doctors on our sides. And if doctors are mad enough about MIPS and ACOs applied to Medicare, we're going to lose most of the profession if they get wind of what Bernie has in mind for them. They're going to be looking at MIPS and ACOs for the entire population.
I just have a quick question. I wonder, to get back to what you were saying before about the barriers to why people aren't maybe listening to us or asking us our opinion, is that we are perceived in some way as another lobby organization, because we as physicians, even though speaking personally as a primary care physician, maybe less so, we're the ones to gain from a fee-for-service system. And so I just wonder if that resonates at all, or whether you think that could be playing a role. And then I guess my other question would be, in that value-based care kind of model or paradigm, have people been talking with the legislators about how faulty those metrics are, and about how that really doesn't, we don't really have any data to say what produces more value? Like, we have no objective measures in order to determine value for a population.
I think that your question about whether physicians are quote unquote tainted because you're going to benefit from fee for service, I think that's true only when you're talking to legislators or MedPAC or the Institute of Medicine or whatever their new name is, or the Robert Wood Johnson Foundation or SEIU. These august organizations that have been peddling the managed care hype for 50 years. For ordinary people, doctors are highly credible. You are very credible. And I was extremely happy in 1989 to see the first PNHP doctors in Minnesota start joining a coalition I was working with for single payer. So on balance, the involvement of physicians and PNHP in particular in this campaign is incalculably valuable. And I just wouldn't worry about it. I think you should feel free to talk about exactly what I just said as a physician. It helps, someone like me that doesn't have a MD degree to say this. I understand that. What was your second question? Oh, is anybody telling the policymakers what I just told you? No. That's why I fear Pramila is going to come into this meeting having gotten an earful about how important it is to measure everything that moves in clinics and hospitals in this country, and then treat doctors and hospitals like rats in a Skinner box. Well, if they're not testing enough, giving diabetics enough eye exams every year, punish them more, and those that are above average, give them more money. That's the crude thinking. I suspect very few people have approached Pramila to give them the point of view I gave you in my presentation, but it's extremely important. What I hope is going to eventually happen is that the news that doctors are burning out will finally sink, and they're burning out because they're overwhelmed by having to click on computers to satisfy their overseers. They're losing autonomy, more and more autonomy year by year. And it drives me nuts to see the American Medical Association support yoga and counseling, when what we really need is a strong voice saying, get managed care off our backs. So sad to say, no, I don't think Pramila and other legislators and policymakers have heard what I just said and what I believe you're saying, that measurement is crude, it's causing more problems than it's worth. And by the way, I think it's important to say to Pramila two things. We don't see measurement as the enemy. Any quality improvement typically requires some kind of measurement. The issue here is linking penalties and bonuses to crude measurement. That's the sin.
Well, thanks so much. This was a wonderful presentation, and you know, we've got all kinds of stuff trying to record it, and I hope it's coordinated enough that it makes a great video, because we certainly heard a lot of information here that we need to stick in our brains so we can spit it out as necessary.
David, why don't you guys, as individuals or as a group, tell me what you think of that document, whether it's adequate. I agree, it could use a lot more documentation, and I'd be happy to provide it. I really think this meeting is important, and I want to help you prepare as best I can.
Okay, well, thanks everybody for coming.
Thank you.
Thank you. Thank you.